Hello dears. Today we can discuss an important part in the management of neurogenic bladder dysfunction in patients with spinal cord injury. The pharmacology of lower urinary tract dysfunctions. Before going into the pharmacology proper, we can look into the type and distribution of receptors and transmitters of the bladder and urethra, which is very essential for understanding the pharmacology. First, we can look into muscarinic receptors. There are 5 types of muscarinic receptors in the human body, M1 to M5. But in human bladder, mainly seen are M1, M2 and M3. Of these, M2 and M3 are more important. M2 and M3 are seen in a ratio of 3:1. Most commonly seen is M2. But functionally, M3 is more important and it produces contraction of the detrusor. So, in spinal cord injury patients, there is a shift of predominance from M2 to M3 and this produces uninhibited bladder contraction. There are also cholinergic nicotinic receptors primarily located in the external sphincter. It is also a muscarinic receptor. Okay. Now moving to adrenergic receptors. There are 2 types of adrenergic receptors. One is alpha receptor and other is beta receptors. Alpha adrenergic receptors are seen throughout the bladder but predominantly in the trigone, bladder neck and urethra. They produces contraction of urethra. There are 3 subtypes, one alpha 1A, alpha 1B and alpha 1D. Beta receptors whereas are seen mainly in the dome of the bladder, body of the bladder. There are 3 subtypes here also, beta 1, beta 2 and beta 3. Functionally, it produces relaxation of the detrusor muscle. This picture shows the distribution of receptors. Diagram A shows alpha adrenergic receptors, which we can see that these are seen throughout the bladder and urethra, but more predominantly in the trigone, bladder neck and urethra. Whereas in picture B shows beta receptors. They are largely seen in the body of the bladder or dome of the bladder. In picture C, we can see cholinergic receptors or the muscarinic receptors throughout the body, base of the bladder and urethra. Other receptors and transmitters are, there are different types. Each one has got either an excitatory or an inhibitory action. Of this, the purine receptors P1 and P2 are actually located on the small nociceptor sensory fibers as peripheral extension of sensory nerves and involved in the initiation of pain. They helps in voiding of the urine. Then VIP or vasointestinal peptide, which is excitatory in action. Then opiate receptors produces relaxation of the bladder. They are seen in the afferent part of the dorsal horn and several supraspinal regions. Neuropeptide Y and tachykinins produces excitation of detrusor, whereas prostaglandins produces relaxation of the urethra. Parathyroid hormone related peptide produces relaxation of detrusor and serotonin produces urethral muscle contraction. Now moving to the pharmacology proper. There are 2 types of failure. One is storage failure and other is emptying failure. In both cases, it could be either at the level of bladder or outlet, or it can be a combination. The pharmacological agents with action on the bladder are antimuscarinic agents, which is the most commonly one used, antimuscarinic agents with mixed actions, that is more than one action, cholinergics, alpha adrenergic antagonist, alpha adrenergic agonist, beta adrenergic agonist, antidepressants, drugs acting on membrane channels, phosphodiesterase type 5 inhibitors, toxins like botulinum toxin, estrogen and other hormones, and other drugs. First, we can look into antimuscarinic agents. Previously, these drugs are called anticholinergic drugs. This actually reduces the normal bladder contraction as well as the involuntary bladder contractions. This action is by selectively blocking the muscarinic receptors. So it is used for treating neurogenic detrusor overactivity. The side effects of these antimuscarinics are mainly dry mouth. It also produces pupillary dilatation, blurred vision, tachycardia, drowsiness, and constipation. These are, now we can look into the pharmacological agents of antimuscarinic group. First one is atropine. It is now used rarely because of its side effects. Propandolin bromide was previously used, but now it is not common in usage. Can be given at a dose of 15 to 30 milligram TAD. Now the commonest drug is oxybutynin, commonly used is in a dose of 5 milligram QAD. Can also be given as SR, slow release form, with 15 milligram daily, once or twice daily. The oxybutynin preparations are available for intravesical instillation, transdermal application. Also, there are extended release oxybutynin and immediate release oxybutynin. Immediate release oxybutynin is used for the treatment of detrusor overactivity. After oxybutynin, next one is tolterodine. Tolterodine is actually a long-acting anticholinergic. A dose of 4 milligram daily is given. Fesoterodine is a newer agent similar to tolterodine. Dose is 4 milligram daily. Then comes darifenacin. Darifenacin is actually a M3 receptor antagonist. Dose is 7.5 milligram to 15 milligram daily. Then solifenacin is given in a dose of 20 milligram BD, and solifenacin is given in a dose of 5 to 10 milligram daily, and trospium is given in a dose of 20 milligram BD. The next is antimuscarinics with mixed actions. That is, as I have already said, these drugs will be having more than one action. First one is oxybutynin. Oxybutynin has got antimuscarinic action, skeletal muscle relaxation effect, and local anesthetic action. This local anesthetic action is useful in intravesical use. Second one is propyvarin hydrochloride, has got antimuscarinic and calcium antagonist action. Dose is 30 milligram daily or 15 milligram TAD. Advantages are propyvarin has got less mouth dryness than oxybutynin. Then third is flavoxate hydrochloride. It actually has got three actions: calcium antagonist activity, inhibits phosphodiesterase activity, local anesthetic activity. No antimuscarinic effect is seen with flavoxate hydrochloride. Dose is 1200 milligram daily. Next group is cholinergics. Cholinergic drugs are drugs who has got action on acetylcholine. There are two types of cholinergics. One is directly acting and other is indirectly acting. Directly acting means has action on muscarinic receptors And indirect acting means it increases the availability of acetylcholine. Muscarinic agonist, it's actually a directly acting one, are betanicol, muscarine, pilocarpine, etc. It produces stimulation of acetylcholine release. Second one is acetylcholinesterase inhibitors. It indirectly acts by increasing the acetylcholine levels. It acts by inhibiting the acetylcholinesterase. Examples are physostigmine, neostigmine, edrophonium. Then comes the nicotinic agonist. This mimics the action of acetylcholine at nicotinic acetylcholine receptors. Examples are lobeline, nicotine, and choline. A mode of action is it stimulates the striated muscle cholinergic receptors, nicotinic receptors. Alpha adrenergic antagonist. It decreases the outlet resistance. Main action is to decrease the outlet resistance. Effective for treatment of both storage and voiding symptoms in men with benign prostatic hypertrophy. Commonly used drugs are tamsulosin, sildosin, alfuzosin, etc. Then moving to alpha adrenergic agonist. It increases the urethral tone and closure pressure by direct stimulation of the alpha adrenergic receptors. Examples are ephedrine, phenylpropanololamine, pseudoephedrine. Then comes the beta adrenergic agonist action. It causes the relaxation of the detrusor muscles and it increases the bladder capacity. There are three types of beta receptors: beta 1, beta 2, and beta 3. Examples are ephedrine, salbutamol, etc. Mirabegron is a beta 3 agonist which is useful in the treatment of detrusor overactivity. Dosage is 50 to 100 mg daily. Side effects are hypertension, constipation, headache, etc. The new drug Solabegron is under clinical trial phase 2. Comes the antidepressants. Antidepressants action is it causes depression of the bladder contractions and it increases the outlet resistance. The only risk is it produces obstruction in patients with men in the old age with benign prostatic hypertrophy. Second drug is the imipramine. Imipramine is the first drug is imipramine, which is a tricyclic antidepressant. Dosage is 25 mg TAD. Second one is doxepin, which is a potent tricyclic antidepressant. Dosage is 50 mg daily bedtime. Third one is milnacipran hydrochloride, which is a serotonin norepinephrine reuptake inhibitor or SNRI. Other one is paroxetine hydrochloride, which is a selective serotonin reuptake inhibitor or SSRI. And finally, duloxetine, which is a noradrenaline serotonin reuptake inhibitor. Then comes the membrane channel blockers, which are mainly calcium antagonists and potassium channel openers. Therapeutically, it is supposed to inhibit the detrusor overactivity, but there are no clinical evidence regarding this. Verapamil and nimodipine are the examples. Potassium channel openers suppresses the detrusor contractions. It also contributes, the potassium channel actually contributes to membrane potential. So it is supposed to regulate the tone of the bladder, but it is not a therapeutic option. Then comes the phosphodiesterase type 5 inhibitors. It produces relaxation of the detrusor, prostate, and urethra. Acts through nitric oxide CGMP system. Examples are sildenafil, tadalafil, vardenafil, etc. Long-term results are lacking. In some patients with erectile dysfunctions and overactive bladder, it is found to be useful. Comes the toxins. Toxins, intravesical therapy for lower urinary tract dysfunctions has got two potential advantages. One is high concentration of drugs can be given to the bladder tissue. Second is the off-target effects of the drugs given systemically can be avoided through this method. Of the among toxins, botulinum toxin is the most commonly used. Its main action is to prevent the release of acetylcholine from cholinergic nerve endings. So it reduces the contractions or it makes the bladder detrusor muscle contractile. Action usually lasts for 2 to 4 months. During this time, it is thought that axons develop lateral sprouts and eventually regenerate completely. The third action is it produces sensory impairment in the bladder. This is due to the botulinum. This is due to botulinum inhibits the spinal cord release of glutamine, substance P, and calcium gene-related peptide. The side effects of botulinum toxin are bladder pain and UTI. Then coming to the next group, capsaicin and resiniferatoxin is vanilloids. These are supposed to decrease the detrusor overactivity and urgency. However, the results are not consistent. Now, moving to hormones, we can see that estrogen has got actually there is no evidence in the lower urinary tract dysfunction, but it is seen that it is it has got some use in urogenital atrophy, vaginal dryness, etc. Then comes desmopressin. It is useful in nocturnal enuresis in children and nocturia in adults. In old age people, it may produce hyponatremia. Then opioid antagonist is another one which has got the examples are diphenoxylate and loperamide. Other drugs commonly used are baclofen and dimethyl sulfoxide. Baclofen is actually an inhibitor of CNS and it decreases the micturition. Causes C fiber activation in urothelium and efficacy is poor. Second one is dimethyl sulfoxide. It has got multiple pharmacological actions. One is vasodilator property. Second is membrane penetrant property. Third is anti-inflammatory property. And fourth is local analgesic actions. So, we can arrange medicines as per their actions. For facilitating bladder filling, we have to inhibit the bladder contraction or we have to decrease the sensory input. And at the outlet level, we have to increase the outlet resistance. So, which are the drugs for inhibiting the bladder contractions? That is anti-muscarinic action, mainly oxybutynin, tolterodine. Second one is alpha adrenoreceptor antagonist, which is mainly used in men with BPH, tamsulosin, etc. Beta adrenoreceptor agonist, beta 3 agonist, is a mirror background. Then antidepressants like imipramine and duloxetine. And toxins used are botulinum toxin. Now coming to increasing the outlet resistance, alpha adrenergic agonists may be used. Anatomical factors cannot be treated pharmacologically, and to it is thought that estrogen vitamin D3 has got some action in increasing the outlet resistance, but evidence is lacking. Now coming to pharmacological treatment for facilitating the bladder emptying. For increasing the bladder emptying or voiding, we have to increase the bladder intravesical pressure or contraction, or at the outlet level we have to decrease the resistance. So for increasing the bladder pressure or contraction, we have to give parasympathomimetic agents like bethanycol, prostaglandins, opioid receptor antagonists. For blockers of inhibition, we can give alpha adrenoreceptor antagonist, and for opioid receptor antagonists can also be used IV naloxone. It is not common. Then for decreasing the outlet resistance, we can give at the level of smooth sphincter, we can give alpha adrenoreceptor antagonist, and at the level of striated sphincter, we can give benzodiazepines, dantrolene, baclofen, etc. So this comes to the end of this pharmacology section. Next class will be about investigations in lower urinary tract dysfunction. Thank you.